Hey, Akshay.
Hello, good morning.
Oh, good. Okay, so this link works. Perfect.
Yeah. Did you receive? I mean, I sent it again just a few minutes ago to your hot.
Okay, I didn't get that one, but this works.
Great. Perfect. How are you
Perfect.
doing? If you want, you can check your screen share once.
Yep, we'll do it right now.
Mhm.
How's that? Is it good? You're on mute. Everything good?
Yeah, everything's great. And great illustration.
Perfect.
Yeah.
Thanks. Thanks for all your efforts. That's a lot of work you're doing.
Oh no, I mean, it's a privilege actually to have you here. And I remember I listened to this topic. The first time I listened to you was this topic, and you talked of a teacup. If
Well, the teacup is still there.
I hope, yeah. So I'm looking forward to listening to it again because it's one of the analogies I've never forgotten. That was during my residency days, a long time ago.
That's funny. Yeah, I run into people that still remember that were residents and some were medical students and then some senior people too. I guess when I think about it, the first time I gave a talk in India was in 1996. I think January 1996. That was the first time. So it's been, wow,
Wow,
almost 30 years now. Yeah.
absolutely. I had listened to you when you had come to Tata. I think that was 2011 or 2012, 2011, I think.
Oh, yeah. That's when we had that big session at Tata Memorial.
Yeah, that's right. So I was in KM at that time, and we were
Oh.
all very excited and doe-eyed to see you.
Now there's so many people. I think I was one of the few at that time that was actually doing head and neck, and that was of the Indian diaspora at the time. Now there are lots of people, but it's good to be exposed to another generation.
Yeah, absolutely. I mean, we all sort of read your book, so I think, and many, at least as far as the Tata residents go, they all still refer to the book.
Oh, thank you.
Yeah, especially I remember the anatomy, the cut sections and the anatomy. That was just brilliant because that was a time
Okay.
there was nothing online. So
Right, right.
yeah,
Yeah, it's amazing how things have evolved
I know.
over time.
Yeah.
How many people do you normally get attending this?
So we get anything from, so depending on the topic, a more common topic like this would be 250 to even 400.
Oh my
Um,
gosh.
yeah, and usually, it started with when we analyzed our data a year and a half ago. It was around 26 or 28 countries median. Now we usually get 30 to 30, 35 easily, generally. They're up to about 35 countries.
That's phenomenal. That's
Uh,
great.
just,
Yeah, and if you could send me the recording on a video, I'd like to put it. I mean, I'd like to put it on my channel. And the other
yeah.
thing that would be nice too is somehow cross-reference stuff. So, part of it is if somehow we can reference that this was a ref talk, then people can go back to ref and vice versa. Um,
Hmm.
some way to try to align that. But yeah, if you could
Hmm.
send me the listing, I would like to upload it.
Yeah. So I'll do that immediately after the talk. Zoom allows us to simply just share the link. We'll do that.
Okay, that'd be great. And then I could probably download it, I bet. So okay,
Yeah.
that'll work.
Perfect.
Yeah, we have over 2,500 people now on that are subscribing to that channel. It's amazing how the internet works.
Absolutely. I mean, you can reach people you never expected to reach.
Yeah. I mean, I saw the power of this when I was in Michigan State, where I just loaded a few of these talks online, and the next thing I know, there were about 1,000 people had viewed it, and then I looked at the analytics about where they came from,
Yeah.
and they're from all over the world.
Yeah,
And then
absolutely.
even when I would give my talks, they said, "Yeah, I saw your talk on this," and I said, "How did you?" see it. It's just kind of popped up. So it's kind of a good way to give back to society, I guess, in a small way.
Absolutely. So, where are you currently placed? Are you in the US?
Yeah, I'm in Indianapolis.
Okay. So, our daylight
Yeah,
saving calculation worked properly.
worked perfectly. Yeah, the only thing I lost out on my tennis today, but
Oh,
it yeah, I usually play tennis on Sunday mornings. I think I upset my partner because I tried to squeeze something before this, but it just couldn't work it out. So hopefully he'll forgive me over time. I played yesterday. It's actually nice today, so I think this is going to be a golf day for me, at least to go out and try to swing a golf club again in the afternoon. But I have as much time as you want for my wife's out of town, so I have as much time as you want to go over any questions that you may have.
absolutely.
So
Surely,
yeah,
yeah.
I can stay as long as you want. I may have to take a bathroom break, but I can stay as long as you want. Actually, let me do that now. Let me just run use the restroom real quick. Okay.
Yeah, yeah.
I'll be
You
right
tell
back.
your friend that the cricket finals are happening, and that's why you did not go for the tennis match, you know. So, I don't know if you follow cricket, but India is in the finals of the Champions Trophy, which is like this big international event.
Oh my
So,
gosh. Is it happening now?
it's happening now. Yeah, I did not realize it when we planned this, but I'm sure it won't matter. You know,
So I may get beaten out
that's
by
a
the
big long
cricket.
match. No, it's like a 10-hour long match, so don't worry about it.
Oh gosh. Well, hopefully people will record it. I'll
Yeah,
be
no,
right
no, I
back.
think they'll be logging in. Don't worry.
Okay.
Yeah.
Hey, I'm back.
Great. So I can actually, if I can share my screen again with your introduction
Okay.
and introduce you in just about a minute. I think it's almost 7.
Sounds good.
Yeah, so the peak attendance reaches at around 7:15. You know, Indians always log in a little
Yeah,
late. Yeah, but it,
Indian Standard Time.
yeah, yeah, yeah. Yeah, you're well aware of it, aren't you?
100%.
Just one more minute to go and then we can start.
Yeah, no problem. I'm just putting my YouTube channel at the end of it.
Yeah, thanks. Okay, it is 7. So I'll just introduce you, Suresh, and then hand it over. Hello,
Sounds
everyone.
perfect.
Akshay Baheti, and welcome to today's very special and privileged webinar. We are so glad to have with us back on the platform Dr. Suresh Mukherjee. Suresh really needs no introduction. He's been, a prolific teacher, prolific educator, and I'm sure all of you have read his book, Peter Som and Mukherjee. Um, And he's been kind enough to agree to do a series of webinars with us, every 2 to 3 months, which will essentially cover everything in head and neck over, the next few years. And we're going to start with the visceral cavity. So we're going to start today with the anatomy and pathology of the oral cavity. Just to let you know a few of his current affiliations, he is clinical professor of radiology and radiation oncology at University of Illinois and Robert Wood Johnson Med School, Rutgers University. He's faculty at Michigan State University, National Director of Head Neck Radiology at ProScan Imaging. And there are just too many accolades to really put on this small screen. So, Suresh, it's, just to let you know, today is a special day in the sense there's the Champions Trophy final happening. And in Mumbai, there's this big concert happening with Green Day, Shawn Mendes, a lot of very famous performers are there. So, I mean, it's just apt that, one of the most famous radiologists is also having something to, talk about today on our platform. So, really glad to have you here and looking forward to this session.
Thanks a lot, Akshay. It's a real pleasure to be here. Thanks for putting this together. And I'm so delighted so many people could show up. I know how important cricket is. Years ago, when I did my rotation, I was actually a medical student, did 6 weeks in Calcutta. And I was there, Akshay, for the first one-day match in Eden Gardens when India played Pakistan. And so it was one of the incredibly exciting moments of my life. Now everything's sort of switched over to 2020, I think. But I think the 10-hour match is amazing. So, and everywhere I go, I'm always proud to hold up the Indian flag because everyone in the world knows that India is the number one in cricket in the world. So it's great to be here. And so I totally understand if hopefully now you can record part of the match or something like that. But I appreciate everyone being here. And also, actually, it's really for me, it's exciting to actually kind of create these series of educational talks because it's always nice to have a talk, but what we hope to do in something like this is to kind of create a curriculum where we can kind of step through stuff. So thanks for doing this. So what I'm going to talk about is anatomy and pathology of the oral cavity. And what we're going to start off with is that what we're going to do is that we're going to go through all of these oral cavity subsites. So this talk is going to be on the oral cavity. So next time we come back, we haven't finalized the curriculum, but we'll probably move this square yellow box posteriorly to talk about the oral pharynx. But we're going to really take our time and talk about the oral cavity and the various contents of the oral cavity. And those are the lips, the buccal mucosa, the floor of the mouth, the alveolar ridge, the hard palate, the oral tongue, and the retromolar trigone. Now, these are the contents, and I don't want you to worry about these because we're going to go through each and every one of these areas. And we're going to take this in great detail, and we're going to use various illustrations, and we're going to comment about really the unique pathologies that occur in this area. So don't worry about trying to memorize all this stuff here. If by the end of this talk, if you don't have a better sense of it, it's not your fault. It's my fault. So the first area that we're going to talk about is the buccal region. And I use the term buccal region back when I was a fellow, and I think the paper's still out there. We did a radiographics paper on the buccal space, and the buccal space is a true space that involves the head and neck. But as you all probably know, I actually, in addition to being a radiologist, I actually see patients once a week. And we don't necessarily use the term buccal region. We use the term buccal space. We tend to use the term buccal region. And part of it is the fact that if I'm a radiologist and I talk about the space, I'm going to talk about the buccal space, which is located here. So there's a superficial and there's a deep portion of the buccal space. And this little structure right here that's traversing and arcing over is the parotid duct. And this little vein right here is the facial vein. So all of this is sort of the buccal space. Now, if you look at the anatomy of this area on this Netter diagram, this is the buccinator muscle going into the lip. And we'll talk about this area later, but this is the superior constrictor muscle, and this is the famous pterygomandibular raphe. And we'll have a lot more to say on this when we start talking about the retromolar trigone. But the reason why I mention this is that this is the buccinator muscle. Now, This is in general what we think about when we talk about the space, but in real clinical practice, what ends up happening is that we really look at this sulcus right here. So there's a sulcus right here that's located between the inner portion of the lip and the outer portion of your gingiva, and this is called the gingival-buccal sulcus. So the majority of the pathology that I end up seeing is involving this gingival buccal sulcus. So back when I was a resident, a fellow, and a junior faculty, as radiologists, we always talk about the buccal space, but I really want to focus on this gingival buccal sulcus. So this is just a schematic illustration of a tumor that's involving, if you will, the buccal region, and it's located in the gingival buccal sulcus. So when we look at tumors that are involving the gingival buccal sulcus, the most common tumor that you're going to end up seeing is squamous cell carcinoma. So what I want to do now is introduce a couple of concepts to you. So as we go into the head and neck, when I was a resident and a fellow, and I still do this, we talk about symmetry. So you draw a line down the middle and you compare one side to the other. And it works pretty well. That gets me through about 80% of the cases. But you'll see this as we kind of step through this course. What I want to also talk about are tiger stripes, and you'll see the tiger a little bit later. But when I'm looking at pathology that's involving this area, also when we're looking at this gingival buccal area, you can see an area of fat right here, then you see muscle, and then you see fat. Those are beautiful little tiger stripes right here. And in fact, when you look at this normal image right here, you can see a nice black stripe, a white stripe, a black stripe right here. So you can see these nice little stripes. So when I'm looking at tumor spread, I look at symmetry, but especially in the head and neck, because I know that there are striations between fat and muscle. I also look for these tiger stripes. So we'll talk about this later as we kind of step through this area, because it really is important when we talk about treating oral cavity cancers. But this is a classic example of squamous cell carcinoma. Now, being in the United States, one of the most common causes of squamous cell carcinoma involving this gingival buccal sulcus is snuff dipping. So I don't know if you've dipped snuff or not, but basically you can take tobacco, you put it in the gingival buccal sulcus, which is located here, and you kind of suck on it. I've never done it before. But on the other hand, because I am of Indian diaspora and I've come to India numerous times, you guys are all familiar with this. You're familiar with the betel nut. So you put the betel nut right here in the gingival buccal sulcus, and whether it's due to direct toxicity, whether it's due to alpha toxins, no one's 100% sure, but this results in dysplasia that can either involve the inner surface of the lip or the outer surface of the gingiva involving the mandible. Now, you say, well, why are you so sure about this? Well, because I see patients once a week, a lot of our patients that come into our clinic are actually from India. And I've seen several cases now, and it's really quite dramatic, of wonderful Indians that come in that have done betel nut for years. And basically what it does, it looks like a whitish dysplasia that can either be located along the lip or along the gingiva. So literally you can see this betel nut right here, and it literally looks like a whitish area that's directly adjacent to that area. So, when we talk about cancer prevention, we always say don't smoke and don't drink. And I can assure you that if you're doing a lot of betel nut, you're really at our high risk of getting squamous cell carcinomas involving the buccal region. Now, over time, when I was talking to Akshay, the first time I gave a talk in India was in 1996. My father passed away in 1995, so I brought his ashes to actually Haridwar. So when I was bringing his ashes, I spent a couple of weeks giving some lectures in India, and that was the first time I came. And one of the things that I've evolved over time is that I've become a big advocate now of actually performing these puff cheek techniques. Because when we look at squamous cell carcinomas like this, if I draw a line down the middle, compare the right side to the left side, I can see this tumor right here where the yellow arrow is. But on the left-hand side, you see the fat right here? This tells me that this is normal on the left and there's a tumor. But when I'm looking at this tumor, I don't know whether it's involving the lip or whether it's involving the gingiva of the maxilla. So as a result, the clinicians can see it, but if you do a repeat study and you do the puff cheek techniques, you can see very nicely this tumor right here, all of this abnormality right here. This is all tumor involving the lip, but in this case, not the gingiva. And when you draw a line down the middle, compare the right side to the left side, then we can see the normal appearance of fat on the left side. So this increases our confidence that there's a tumor, and it also tells us it's involving the lip and not the gingiva. And here's another example here, another patient with puffed cheeks. Notice my nice tiger stripes here. I've got a white, I've got a black, and then I've got a gray. But as I come medially, all of my stripes are obliterated. And again, this just tells me that this tumor is involving the lip as opposed to the gingiva. Now, some of the pitfalls again on CT is that if you do have a patient that has a lot of dental amalgam, sometimes you can never see where those tumors are located. So this was a patient that had a CT scan. Unfortunately, it has a lot of dental amalgam. Clinically, we can see that tumor, but on the other hand, we just can't see it on the CT scan. And this is where the PET CT is actually very helpful. So this is a focal of abnormal uptake, again, involving the gingiva buccal sulcus. You can't see it on CT. Now, one thing that I will say in the United States, and as much as I travel, I talk to different people and get different views about how you stage squamous cell carcinomas, the oral cavity. In general, in the United States, all of the patients end up getting PET CTs. So fortunately, if you do have a patient with squamous cell carcinoma involving this area, we typically do get PET CTs for distal staging. So here we can increase our confidence where that local tumor, where that tumor is localized. And the reason our surgeons tend to do this in the US, even though that most oral cavity cancers are treated with with surgery, they do want to make sure there's no distal metastases. So we do stage to look at the neck, but on the other hand, if there is a lesion involving the lung or if there is a lesion involving somewhere else, our culture, if you will, our medical culture and our surgeons really found that information on PET CT very helpful in order to properly stage and treat these patients. So the number one cancer that you'll see in the buccal region is going to be squamous cell carcinoma. Now, in my experience, the second most is either going to be this tumor, which is lymphoma, or the next one that I'm going to show. Now, both of these are example of lymphoma involving the buccal area. So on the right here, this was an example of lymphoma, again, involving the buccal region. You can draw a line down the middle, compare the right side to the left side, and you can see this is involving that buccal area. Now, this was an example of a case, I actually got this one right. I don't know how I got it right, but this is a nice little plaque-like abnormality that's arising, again, the gingiva buccal sulcus. So we sometimes tend to forget about lymphoma, but if I see plaque-like lesion right here, which is well below the surface and it's not on a mucosal surface, and I see something like this, I do think of lymphoma. So this was an example of lymphoma involving the gingiva buccal region or the buccal region. Now, the next one are other lesions that can involve this area, and this is the classic minor salivary gland tumor. Now, one thing about this always confused me. So, I'm reading this stuff and I'm like, what is a minor salivary gland tumor? I never really understood the concept, and it took me about 30 years to figure it out. Eventually, I get it. So if I have a tumor that's like a mucoepidermoid, as is seen here, or potentially a adenoid cystic carcinoma, et cetera, and it arises back here in the parotid gland, well, then I can say it's a salivary gland tumor. But remember, as the head and neck develops, you can have these small little salivary rests occur elsewhere in the head and neck region. And as you'll see, they can occur in the hard palate, they can occur in the soft palate, and they can occur anywhere in the head and neck. So you can have these little rests occurring in this gingival buccal area, or in this case, truly in the buccal space. And as a result, this is why you end up getting these minor salivary gland tumors. And in general, when they arise in this area, unlike the parotid gland, they tend to be malignant. So this is an example of a mucoepidermoid carcinoma involving the buccal region. And this was an unfortunate case. This was a 24-year-old that I actually saw in clinic. This was an example of a sarcoma that was involving the buccal region. Now, why do sarcomas arise in this area? Because they're of mesenchymal origin. So what's mesenchyma? Mesenchyma means muscle, it means fat, etc. Sarcomas can arise anywhere in the body. So for instance, you can take the same piece of tissue, put in the leg, and you're going to have the same differential diagnosis for this type of tumor. So as a result, in the head and neck, when you are building your differential diagnosis, you always want to include squamous cell carcinoma, you want to include lymphoma. In the head and neck, you always want to include minor salivary gland tumors, and you also want to include sarcomas. Why? Because there's fat, there's muscle, there are nerves, there's skin, so on and so forth. So you can have sarcomas arising from any parts of these tissues. Now, this was an example that's a little bit less common, but if you are working in a cancer hospital, so for instance, Akshay and I were talking early in 2011, I came and gave a day-long seminar at Tata Memorial Hospital, which is a big cancer hospital. And so if you do have patients that have head and neck cancers that are recurrent, you can actually have these tumors arise in a special group of lymph nodes that are called the facial lymph nodes. And one of those facial lymph nodes are located in the buccal area. So if I have a patient that comes in and they've had a head and neck cancer, and now all of a sudden I see this rounded mass in the buccal region, well, I always have to wonder, is it possible this could be a recurrent tumor involving the buccal lymph nodes? And this is what this was. So this was a metastases to involve the buccal lymph nodes. And this was from the paper that we published. Wow, it's been so long ago, probably about 20 or 30 years ago. But it was one of the first papers on looking at the the facial lymph nodes in the head and neck. So the next thing about the buccal region that we have to consider is that you can have a variety of infections arising in the buccal region from odontogenic origin. Now, you know me, I've been doing this for a while, and one of the things that I like to do, I don't read a lot of novels, but I like to read books and I like to read the old literature. And years ago, there was a person named Laskin that actually wrote a paper on odontogenic infections and how they can lead to head and neck infections. And it was really one of the best papers I've ever read because he went through and identified if you have an infection right here involving the mandible and it erodes the outer cortex, well, this can result in a little abscess right here involving the buccal region, and then you can have this soft tissue swelling. And when you mag up on it with bone algorithms, there's that subtle little erosion. So anytime that someone comes in with cheek swelling, and they have a fever, I want to make sure they're not diabetic because it could be a really, really aggressive invasive fungal sinusitis if they're immunocompromised. It could be due to a bug bite. I've seen, various infections from various bugs result in this. But I also want to make sure it's not of buccal origin. So I take a really, really close look at the odontogenic area. And I would say half the time when I see something like this, it is of odontogenic origin. So I want to emphasize to you, when someone comes in like this, just realize that you can have infections arising from the odontogenic area. And this is just an example of a nice example of a true buccal space mass. This happened to be a lymphatic malformation. For me, it's not necessarily important what the path is, but I do want to emphasize the true region here of the true buccal space. And lastly, you can have some foreign bodies. So this was an example of a patient that was, I think this was a stone right here. They had hurt themselves, and this was a foreign body in the skin. And this is kind of cute. I see this sometimes. You've probably seen it before. We always try to educate our techs to make sure the patients have nothing in their mouth. And this was what we call this was a piece of candy. So this was a jawbreaker. The fancy term is comestible. I kind of like candy myself, but if you see something like this was just a piece of candy, again, nicely located in the gingiva buccal sulcus. And so a couple of times I have been fooled on it early in my career, but now I know it's just a piece of candy. So the first area that we talked about was the buccal region, and now we'll go ahead and talk about the oral tongue. And Akshay said there was a big concert going on, Green Day is there, and so on and so forth. So coincidentally, you can remember the oral tongue if you remember another rock group, and that's the Rolling Stones. So, Mick Jagger still has it after all these years. So when we talk about the oral tongue, there are two parts to the tongue. We have this area that's anterior, which is called the oral or mobile tongue. And then we have this group of papilla right here, which is a circumvallate papilla. Right at the apex of the chevron of the circumvallate papilla is the foramen cecum. And just posterior to this is the tongue base. So when we talk about the oral cavity, what we're going to be doing is we're going to be talking about this area which is anterior to the circumvallate papilla. Now, just for completion's sake, there's a little muscle right here. This goes from the palate to the tongue base. This is the styloglossus muscle, and this is the anterior tonsillar pillar. The anterior tonsillar pillar is actually part of the oral pharynx. So when we give our talk on the oral pharynx, if Akshay still wants me to do it, we'll talk more about that. But just realize that this is a transition zone between the oral cavity and the oral pharynx. And this is an example here of the oral tongue. Now, oftentimes I'm asked, and you'll see this later when we go through, is how do we know when we're looking at the mouth that we're looking at the oral tongue? And the reason is that if you look real closely, the oral tongue has a lot of traversing fibers like this that go from left to right, and it has a high density of fat. So when you look at this Netter diagram with a leap of faith, you can actually see these little linear lines here on the right and the left. And then when you look at the oral tongue, you can almost see these lines as well. So this tells me that we're looking at the main portion of the oral tongue. And then when we talk about the floor mouth, we'll see another radiological landmark. So when we look at the oral tongue, the most common tumor to involve the oral tongue is going to be squamous cell carcinoma. So these are two examples of squamous cell carcinoma. There's nothing specific about this. When I see patients that have squamous cell carcinomas, the vast majority are arising from the mucosa. They're associated with smoking and drinking. Also they're very painful. I mean, these cancers are painful. So it's no real shock when we see patients with squamous cell carcinoma. So I'm not going to spend a lot of time going over the imaging findings. But what I do want to emphasize is the depth of invasion and the staging of this. So as you know, I've been on the AJC staging committee for the past 20 years. And so when we look at the staging, the new AJCC staging edition talks about this concept of depth of invasion. Now, what I want to emphasize to you is that tumor thickness is not depth of invasion. These are two completely different concepts. So a tumor thickness is the thickness of the tumor. So if I see a patient that comes in like this that has a tumor involving the oral tongue, and I do my CT scan and I do my measurements. So these are the measurements that I would make. This is craniocaudate and this is transverse. This transverse area is not depth of invasion. This is tumor thickness. Now, what is depth of invasion? The depth of invasion is a pathologic diagnosis where the pathologist takes the cross-section of the microscopy of the tumor. They look for the basement membrane, which is this membrane just below the mucosa of the tongue, and they draw a line. And this line approximates the basement membrane. Now, I don't remember much about histology. The only way I got through, I did not do well in histology. I just remember blue is bad. I don't know if you learned that in Indian medical school or not, but blue is bad. And so when I look at this, I see a lot of blue here. So what the pathologists do is they find the deepest area where they're blue and they make their measurement. And this measurement, this plumb line, is the depth of invasion. In this case, it's 9 millimeters. So as you know, as much as I travel, again, I still see even referring physicians say, please measure depth of invasion on the CT scan. At this point in time, we can't do it. So just realize that this cross section is the tumor thickness. So it does make a difference because the depth of invasion is integrated into the staging system. But again, as I mentioned before, I won't go through all the details, but I did want to mention again that when you measure this cross section, this is thickness. So you should measure the largest dimension of the tumor, but please don't mistake this with depth of invasion because they are two completely different concepts. So when we look at tumors involving the oral tongue, again, with squamous cell carcinoma, and again, this is where I've evolved over time. For the most of my life, I really did advocate CT. But what I have seen is that really MR, I think, is superior to CT for looking for tumors that are involved in the oral tongue. So this yellow arrow just points to a very subtle lesion involving the oral tongue along the surface. So clinically, we can see this, but especially if you have patients that have dental amalgam, it's really, really hard to see. Now, the one thing that I will say is that when you are evaluating patients with MR, please have them hold still. Please talk to your technologist. I work really closely with our techs, and I'm always asked, how can we improve our imaging? Overnight, you can improve your imaging if you just emphasize to your techs to have the patients hold still. And if they hold still and there's no motion artifact, because remember, it takes longer to acquire images on MR than CT, then you're going to start really picking up these very, very subtle lesions. So again, please have your patients hold still. And another example here, this was a patient that had a PET CT, again, lots of dental amalgam, but again, we can very nicely see this on the PET CT. So again, we still use a lot of PET CT, excuse me, a lot of CT to image patients with oral cavity tumors, but realize in certain cases, you are going to see these better on MR and certainly PET CT. So this is an example of a patient that comes in, a child that has a large mass involved in the tongue. And what we see here is an example on the CT scan. We see calcifications. On the non-contrast T1 signal, it's bright. We can see fat. And then we can see here on this arrowhead, we can see the signal loss, which corresponds to this calcification. So if you have a patient that comes in that has calcification and we have fat, well, remember, fat plus calcification equals teratoma. And this is an example of a teratoma involving the oral tongue. And here, what we see here is that this patient actually had a bifid tongue as well. So this is a nice example of a congenital malformation involving the oral tongue, and it was just a teratoma. And these are examples of patients that come in with macroglossia. Now, macroglossia is just a really, really big tongue. But I'll give you a couple of examples from, if you will, my experience, because I'm old enough to say this. So this patient actually has macroglossia because it has diffuse edema. So when I see diffuse edema, the first thing I wonder is that did the patient have an anaphylactic reaction? So the first thing I'll do is I'll see this, I'll call the technologist and I'll say, hey, did this patient have an anaphylactic reaction? If they say no, well, that makes me feel a little bit better. But when I do see something like this, the next thing that crosses my mind is, why did this patient have edema? Then I start asking them if are they on any ACE inhibitors? Because remember, some of the hypertensive medications that we see can actually reduce idiopathic edema. So I always want to make sure that they're not on any type of ACE edema. So we can see this here in the tongue, and another common area that we'll end up seeing is in the retropharyngeal space. So we can talk about that in a future talk. Another example of diffuse macroglossia is amyloid deposition. So occasionally we'll have patients that have amyloidosis. Really no way to make this diagnosis, but if we do see a big tongue, it's certainly in the differential diagnosis. And you can also have vascular malformation. So this is an MR of a diffuse low flow vascular malformation involving the tongue. Us, it can be a little bit non-specific because we would give a differential diagnosis. But once you look in this child's mouth or this young adult's mouth, you can see that vascular malformation. So typically, this is not a diagnostic dilemma where these two can occasionally be a little bit confusing. Now, when we talk about the oral tongue, one of the most common pitfalls that we see is based on understanding the innervation of the tongue. So the tongue is really quite a fascinating structure. I mean, I love head and neck. You guys have figured that out over 30 years. But what I end up doing is that when I look at the oral tongue, the motor portion of the oral tongue is going to be supplied by the 12th nerve, which is the hypoglossal nerve. So that's motor. Now, you do have sensory innervations of the tongue. So the anterior two-thirds of the tongue is really quite fascinating. The anterior two-thirds is our famous chorda tympani. So the chorda tympani supplies taste to the anterior two-thirds of the tongue. So that's just taste. Now, if you look at sensory, the anterior third is a branch of the fifth nerve, which is the lingual nerve. Then you have sensory to the tongue base, which we'll be talking about later in another talk. That's the ninth nerve. And then this little island right here is formed by the 10th nerve. So when we talk about sensory, it's really 4 different nerves that supply this. But from a practical standpoint, what ends where I get confused on and others get confused on is that really it's this motor section. So the motor section is formed by the hypoglossal nerve. Now, the hypoglossal nerve exits the brainstem and it extends through this hypoglossal foramen through the famous eagle's beak. So this sort of looks like the eagle. So you can see the eagle's beak right here. You can see the head, you can see the neck and the body. And that's where the hypoglossal nerve runs through. So one thing that ends up happening is that if you see something like this, and you say, wow, there's something going on in the right side of the tongue. Well, if you look real closely on the non-contrast T1 weighted image, you draw a line down the middle and you compare the right side to the left side. And remember, on a T1 weighted image, fat is bright. Well, this is just fatty replacement of the tongue. And remember, in the 12th nerve, when you stick your tongue out, the tongue deviates to the side of the abnormality. So if I see something like this that's dead midline like this and kind of corresponds to where that motor is, the next place that I have to look for is the basi-occiput and the skull base. Because here on the left side, we can see the normal beak, we can see the normal head, we can see the neck, and lo and behold, there's the 12th nerve running right through the hypoglossal foramen. But on the right-hand side, notice that head has been eroded, and this is a diffuse metastases. And with a leap of faith, you can almost make out, maybe it's one of these dots right here, it's hard to say, but you can tell certainly that the tumor is extending into the foramen and involving the nerve. So this ipsilateral involvement in this case was due to this metastases to involve the hypoglossal canal. So something like this that's sort of straight midline, just remember to look at the basi-occiput. So the next area that we'll talk about is the floor of the mouth. And the floor of the mouth has different names to it. So, we in head and neck, we like to confuse you. So we can take the same piece of anatomy and give it different names. So because I'm talking about the oral cavity, I'm going to use the terminology of the floor of the mouth. But on the other hand, if I'm giving a talk on the spaces, then I'm going to use the term sublingual space. They really are the same thing. So when you look at the floor of the mouth, as this nice little dog is showing right here, this dog is opening its mouth and very nicely showing us this floor of the mouth. Now, Akshay was teasing me earlier. He heard me give this analogy earlier, but I'll give it again. Like I said, I appreciate giving this because now I can introduce myself to a new group of residents. It's really fun. It's like 4 or 5 generations here that I've been able to share these knowledge with. But when you look at the floor of the mouth right here, the floor of the mouth is formed laterally by this part of the mandible. So we have the mandible here, and there's a line right here. And again, the thing that we all have in common, and I haven't talked about CTology or MRIology or Pathology. I haven't talked about any of the new techniques. I have separate talks on those. Today, it's just brute anatomy. So if you went to medical school, you should know this stuff, right? Because you learned it in medical school. So there's a little line right here, which is called the myeloid line. And this myeloid line has a muscle that goes from the myeloid line down to the hyoid bone. So what do you call this muscle that goes from the myeloid line down to the hyoid bone? Well, that's the mylohyoid muscle. So the lateral margin of the floor of the mouth is formed by the mylohyoid muscle, and then the base of this is formed by the hyoid bone. Now, when we look just medial to the mylohyoid muscle, we have a gland right here, which is called the sublingual gland. Then we have a duct right here, and this duct right here we'll see later, but this is actually Wharton's duct. So this is the duct that communicates with the submandibular gland. So the submandibular gland has its duct that runs in the floor of the mouth. Again, we all learned that in med school. These are 2 nerves that we always forget about. This top nerve I just mentioned, this provides sensory to the anterior 2/3 of the tongue. This is the lingual nerve. Then we have a vein, and then there's the motor nerve. That's the hypoglossal nerve. So there's lingual nerve and motor nerve. And then as we come medial to this, we now have a muscle that goes from the hyoid bone all the way up to the tongue. Now, when we talk about the sublingual space, lingual means Latin and tongue, but the way that we confuse you in head and neck is that when we talk about the muscles, we now use the Greek root, and that's glossus. So this muscle right here is not called hyolinqua. It's actually called hyoglossus. So this is the hyoglossus muscle. And just medial to the hyoglossus muscle is the lingual artery. Now, these muscles that run anterior and posterior, that run from the genial tubercle to the tongue, these are the genioglossus muscles. So these are the genioglossus muscles here. Again, we're using the Greek root. So as a result, when we look at the floor of the mouth, the superior margin is formed by the mandible, the lateral margin is by the mylohyoid muscle, and the inferior margin is formed by the hyoid bone. So here we talked about half of it. Now we'll do the full continuum. So there's the mylohyoid muscle, there's the mylohyoid muscle, there's a hyoid bone, here's the hyoglossus muscle. So everything is in this area. And now, Akshay, you can have a little smile on your face because this is my famous teacup. So for me, the floor of the mouth looks like a teacup. So if you can remember a teacup or a coffee cup, just whatever, whatever your cappuccino cup or espresso cup, whatever you want, if you can remember the rim of this is formed by the rim of the mandible. The wall of this is formed by the mylohyoid muscle, and the base of this is basically the hyoid bone, and everything within that teacup or your coffee cup or whatever, all of these structures, the sublingual gland, the Warthin's duct, the lingual nerve, the hypoglossal nerve, the lingual artery, all of this is located in that cup. You'll always remember where the floor of mouth is. So this is just normal structures of the floor of the mouth, just nicely demonstrating here that the genioglossus geniohyoid complex, just lateral to this is going to be the lingual artery. There's our hyoglossus muscle. There's a sublingual gland. There's the mylohyoid muscle. Similar on the MR, it's easy now, right? And look at my stripes right here, nice little tiger stripes right here. There's a sublingual gland, hyoglossus muscle, mylohyoid muscle. So this is the normal anatomy, and the most common tumor that you'll end up seeing in the floor of the mouth is going to be squamous cell carcinoma. So here's an aggressive mass involving the left side of the mouth. It's pretty obvious to see. But what I do want to do is I want to take your knowledge to the next level. All of you can see this mass, but I want you to try to now start to appreciate the symmetry of one side to the other side, and also try to appreciate these tiger stripes. These little stripes are on the normal side. Because as we start talking about more complex structures like the retromolar trigone, this is where these stripes are going to come in helpful. So the most common tumor is going to be squamous cell carcinoma. The second most common tumor is going to be minor salivary gland tumors. So unlike other parts of the head and neck where you have lymphoid tissue, you don't really have a lot of lymphoid tissue in the floor of the mouth. So the second most common tumor is going to be minor salivary gland tumor. Now, I can tell you radiologically, it's almost impossible for me to differentiate a minor salivary gland tumor from squamous cell carcinoma. It's almost impossible. The one thing that I can tell you, if you do have the ability to see patients, the one thing that minor salivary gland tumors have in common is that they tend to be submucosal. So if you have a deep lesion like this, and if you do have a chance to examine the patient and you don't see a mucosal lesion and the patient has pain, they have a palpable mass and it's submucosal, this kind of leads towards a minor salivary gland tumor, but it's not 100%. I just saw a case a month ago where I was hoping it would be a minor salivary gland tumor so I could put on a talk, but it turned out to be a submucosal squamous cell carcinoma. So again, it's very nonspecific. Now, occasionally you can make a diagnosis, and we've seen a couple of these. This was a patient that has a very large fatty mass involving the floor of the mouth that grew over time. So if you see a large mass like this that's fatty, that has multiple striations, this turned out to be a liposarcoma. So, you can have various mesenchymal tumors involving the floor of the mouth like you can anywhere else. And again, we can make the diagnosis based on these characteristic findings. So again, realize in the floor of the mouth, like any other part of the body, the same tissue is ubiquitous throughout the rest of the body, so you can have a similar differential diagnosis. So just realize these sarcomas can arise in the head and neck area. Now, this was an example of a rare case. This happens to be a neuroma. So occasionally, we can have neurogenic tumors involving the floor of mouth. And why is that the case? Because we kind of talked about it earlier. You have this nerve right here, which was the lingual nerve. Then we have the hypoglossal nerve. And remember, we talked about 9 and branches of 7. So anytime that you have neural tissue, you can have neurogenic tumors. So I have seen cases of neurofibromas, especially in neurofibromatosis patients. I have occasionally seen schwannomas, and this happened to be a neuroma. The only way that I could suggest this is notice how it's displacing the genioglossus geniohyoid complex laterally. It is located deep in the floor of the mouth. We can see what it's doing to the mylohyoid muscle. So it sort of maps to that area, but unfortunately it's nonspecific. So I've had cases where I was sure that it was going to be a neurofibroma or schwannoma. And again, it turned out to be squamous cell carcinoma. So when I am giving my differential diagnosis, squamous cell carcinoma, again, is at the top of my list. Now, here's some other pathology that can involve the floor of the mouth. This was an example of a enlarged mass here involving the left neck. This was a submandibular gland that's gotten enlarged. And here we can see this dilated tube, and this dilated tube represents the submandibular duct crossing over the free margin of the mylohyoid muscle, extending to the frenulum. And if you have a little stone right here, you can have obstructive sialadenitis that's giving you enlargement of the submandibular gland. So when you see something like this, a large enlarged submandibular gland, always look at the anterior portion of the floor of the mouth to see whether or not you're dealing with a small little sialolith. If you do have infections involving the floor of the mouth, they can result in a sublingual space abscess. So anytime that you see an abscess right here, remember to look at the mandible. Because as Laskin taught us, if you have erosion here involved in the medial portion of the cortex, you can develop this sublingual space abscess. And in this case, this was due to an odontogenic infection. And here we can see this chronic osteomyelitis. In the old days, we would call this Gaucher sclerosing osteomyelitis because we would make the diagnosis on plain film. Now we'll probably just acute on chronic osteomyelitis. And here we can see the small little periapical abscess, which was the cause of this. Now, if this abscess gets worse and worse and worse, we can have our famous Ludwig's angina. So Ludwig's angina was named after Wilhelm Friedrich von Ludwig at the turn of the century. So this is not a radiological diagnosis, it's a clinical diagnosis. So you end up having diffuse swelling here involving the floor of the mouth, and it can get bigger and bigger and bigger, and eventually it can pinch off the airway. And that's what Ludwig described at the turn of the century. Now, not the turn of 2000, the last century, this is back in the 1900s. So again, it was a clinical diagnosis. So this was an example of clinically Ludwig's angina. We can see replacement of all the fat planes, but this is what we commonly call Ludwig's angina. Here we can see multiple abscesses extending along the fascial planes, and this needs to be drained, as is seen here. So this is true Ludwig's angina. Don't call this Ludwig's angina. This is a sublingual space abscess, but clinically, if they do have beginning to have airway obstruction, you can see the laryngeal edema with these abscesses. This is true Ludwig's angina, and these patients have to be taken to the OR, or these patients have to be treated with aggressive IV antibiotic therapy and have to make sure their airway is controlled. Well, two congenital lesions that can involve the floor of the mouth, these are both epidermoids. So epidermoids are cystic lesions that involve the floor of the mouth, and they arise from this because the face forms as bilateral midline structures. So as this area closes in the midline, you can have a little bit of ectoderm that gets pinched off, and that's why you have these epidermoids, and they tend to involve the anterior portion of the floor of the mouth. Now, you can also have these cystic lesions that involve the floor of the mouth. And if you see something like this that's paramidline, well, this sort of maps to the location of the sublingual gland. So here we can see this is lateral to the, lateral to the hyoglossus muscle, medial to the mylohyoid muscle, right where we would expect to see the sublingual gland. So this is a ranula. Now, if the ranula is located above the mylohyoid muscle, we call it simple, and the surgeons can just go in there and scoop it out. They just marsupialize it. But realize the mylohyoid muscle can have little defects, and this is what we refer to as a boutonniere deformity. So you can actually have defects in the mylohyoid muscle. Look at the normal on the right side. And if you have a defect like this ranula can actually extend through the mylohyoid muscle into the submandibular space, And this is what we call a diving or a plunging or a complex ranula. And if you see something like this, then the surgeons not only have to do an intraoral approach, but they have to do a cervical approach. And this is just an unusual case of an arteriovenous malformation involving the floor of the mouth. I have seen several of these, typically that I've seen are in younger females, oftentimes with pregnancy. So in pregnancy, you have hormonal fluctuations, you have hypervolemia, and sometimes these women have these occult vascular malformations, but because of the hormonal influence, the hypervolemia, all of a sudden they'll present with acute bleeding. And it is really, really scary. I remember back when I was at UNC years ago, we had someone that presents. I remember I literally had to stick my finger in her mouth to stop the bleeding as we moved over to the angio suite. And then we ended up doing an acute embolization in order to temporize that bleeding. So they can be a little scary. So the next two areas that we'll talk about are the retromolar trigone. Now, the retromolar trigone is probably one of my favorite areas. So in order to make the diagnosis of retromolar trigone, you have to name the teeth. So there's a central incisor, lateral incisor, canine, first premolar, second premolar, first molar, second molar, third molar. And that area behind the third molar is called the retromolar trigone. So for those of you that have had your wisdom teeth removed, congratulations. On this webinar, you have the largest retromolar trigones, because now instead of that retromolar trigone being here, it extends all the way from behind the second molar all the way posteriorly. So when we talk about the retromolar trigone, there's some fun anatomy. So we have the buccinator muscle here, the superior constrictor muscle here, and there's the pterygomandibular raphe. This pterygomandibular raphe runs from the back of the myeloid line at the mandible all the way up to the hook of the hamulus. So not only is the retromolar trigone anterior posterior, but you have a craniocaudate extend to it. And the reason why this is so important is that tumors that occur here have a propensity to grow anterior, posterior, and to invade the mandible. So the concept is for the retromolar trigone, if you have a 3-centimeter lesion in the oral tongue, well, it's just going to involve the oral tongue. But think about it, as you'll see on a couple of slides, if you have a 3-centimeter tumor here, it's going to have a propensity to involve the mandible. It's going to have a propensity to extend anteriorly to involve the cheek. It can extend posteriorly to involve the tonsil, and it can grow all the way up to the skull base. And this is one of those examples. So here's a tumor that has a squamous cell carcinoma involving the retromolar trigone. Now, this is an example of a retromolar trigone carcinoma, and I show my tiger stripes here. So draw a line down the middle, compare the right side to the left side. Notice my beautiful stripes here. You see the fat, you see the gray, you see the white. This is all the anatomy of the buccal region and the lip. So this back here is a retromolar trigone. Now look at the opposite side. All of this is tumor. Once you realize the normal stripes on the left side, this tumor just jumps out at you. And notice it has this curvilinear space, this curvilinear orientation. And the reason that's the case is because it's literally trapped behind the back of the maxilla and trapped between the anterior portion of the mandible. And that's why it has this. Now, how high does this tumor go? The surgeons can look in and they can sort of see the retromolar trigone, but look where we are here. Look at the tiger stripe. See the gray, see the black, see my stripe here? Look here, all that stripe is gone. And lo and behold, what is this? This is the hook of the hamulus. So instead of this tumor being just localized to behind the maxillary tuberosity, this tumor is grown all the way superiorly along the retromolar trigone to the skull base. And I can tell you the most understaged tumor that I've seen are retromolar trigone carcinomas, and I am convinced is that we cannot see the full spread of these tumors. So if you really dig head and neck radiology and you really dig anatomy, is learn to look for these stripes, because these are the patients that are going to recur. This is all the way up to the skull base, and this is growing along the retromolar trigone. Another thing about retromolar trigone carcinomas, and I can tell you this because I see patients, is that they have an early propensity for bone erosion. The surgeons may initially think, well, I can see the tumor that's involved in the soft tissues, but because of the proximity of the anterior portion of the mandible with the tumor, you can have this occult bone erosion. And it can get even worse. This is a large retromolar trigone carcinoma. And notice when we look at the fat in the marrow, see how that fat's obliterated on the right compared to the left? So this is all bone erosion. And this was an example of a patient, and I think I was out of town, so luckily I can't take too much blame for this one. But notice if you draw a line down the middle, notice my tiger stripes are gone. There's a retromolar trigone carcinoma. Now, what I want you to do is look at the mandible. See the mandible is gray? See the mandible is white? And then when you give contrast, notice all of this enhancement. This was all marrow replacement. Now, this could either be due to inflammation of the tumor from the tumor, or it could be due to the tumor. Regardless, the surgeons need to look at this. And unfortunately, what happened in this case is that they ended up doing a partial mandibulectomy. They didn't appreciate all of this extension posteriorly. And after doing the resection and after doing the reconstruction with the free flap, they end up getting a positive margin. So unfortunately, I'm still convinced that the reason these patients do so bad is because of all these all of this occult spread. So if you are dealing in a population that sees a lot of tumors, please, please, please remember these potential spread patterns of retromolar trigones, because they have not, I don't think, really been appreciated in our literature. The retromolar trigones can also extend and have infections extend from them. So if you have an infection involving the molar tooth, they can grow posteriorly through the retromolar trigone and present as masticator space infection. And again, look at my tiger stripes. This can be subtle, but here's the masseter muscle. You see the fat right here. Notice how there's a little bump right there, and that's a small little masticator space abscess. And look at the stripe here. See the white, see the black, see the gray? Notice on the right-hand side, there's the white, but that little black is gone, and that tells you that deep extension of the abscess. And another example here, another large masticator space infection. Draw a line down the middle, compare the left to the right. See my nice little tiger stripes here? See how they're gone on the right side? And this is all phlegmon involving the right masticator space. Okay. So just for the sake of time, we'll just go ahead and bump on to the hard palate, and this is the last area. And again, it all comes down to anatomy. The palate anatomy has always been incredibly confusing to me. So I'll go over just a little bit of this applied anatomy. So these portions of the palate right here are formed by the palatine processes of the maxilla. And then behind this in green, we have the bone that we always forget about. And this bone is L-shaped, and this is called the palatine bone. So the palate is comprised of the palatine process of the maxillary bone, and it's comprised by the special bone called the palate, which is really where it gets its name from, but that's identified in green. So when we talk about pathology involving the hard palate, the first thing that we need to look at is this area right here. This canal right here is called the incisive canal. And occasionally what you can have are cysts. So this is a cyst involving the incisive canal. So what we see here, this patient presented with a submucosal mass. I remember this patient, they sort of presented with occasional drainage and then it would go away, and it smelled really bad. So the patient was like, yeah, I also get this bad smell. And the reason is that this was a large incisive canal cyst that was encapsulated. It would occasionally drain, and that's why you would get that sort of smelly fluid that was coming out of the mouth. But this is probably one of the largest incisive canal cysts that I've ever seen. Now, one thing that we will end up seeing more commonly are tumors that are involving the hard palate. So the most common tumor to involve the hard palate is going to be squamous cell carcinoma. Now, I want to point out a subtlety here. So you can all see this tumor right here. Now, think how the surgeon thinks. The surgeon thinks, well, if I see this tumor, I can go in and locally resect it. But with you as a radiologist, what's going to make the biggest difference? Draw a line down the middle, compare the right side to the left side. Notice the teat socket here. You see all the fat right here? See all this whiteness right here? Now, if the surgeon just remove this tumor, they're going to get tumor. But the most important thing for me is notice the grayness here. So this tumor is actually extending laterally to involve the maxillary alveolar ridge. So if the surgeon just resected this tumor, they're going to have a positive margin, and that patient's going to recur. So that's why it's so important to look for symmetry and also look for those tiger stripes, because this is how you really make a difference. So when patients come in with hard palate carcinomas, the doctors, the ENT surgeons can see the tumor, but what they don't know is how much of the bone is eroded. If we say that the bone is not eroded, they can do a wide local excision, but as soon as we say that that bone is eroded right here at the palate, well, lo and behold, the patients now have to go a palatectomy, and the proper terminology is actually a maxillectomy. And this type of involvement is based on us. It's really, there's no way the surgeons could see that. And that's how we make a real difference in how these patients are treated. So the most common tumor that we're going to see is squamous cell carcinoma, but there is a higher density of salivary gland tissues involved in the hard palate and the soft palate. So these are two examples of minor salivary gland tumors. This is an example of a pleomorphic adenoma. We could suggest the diagnosis because there's a little bit of increased T2 signal, but again, it's pretty nonspecific. This still needs to be biopsied. But in this one, we can probably suggest that it's more aggressive with all the bone erosion, and this happened to be a mucoepidermoid carcinoma. So points that I want to make on this is, number one, when we talk about hard palate cancers, please, please, please look at the erosion here involving the maxilla. Please, please, please comment on the erosion involving the hard palate, because these patients now have to undergo a maxillectomy. But when you have these tumors that are extending posteriorly into the hard palate, you need to take a real close look at these foramen right here, because back here are the greater and the lesser palatine foramen. So when you look at these foramen, this was an adenoid cystic carcinoma. We know that it eroded the maxilla, but realize we have some nerves right here that extend all the way up into the palate, into my favorite fossa, which is located between the pterygoid plates and the palatine bone. That's the pterygopalatine fossa, and this is the sphenopalatine ganglion. So this adenoid cystic carcinoma is associated with enlargement here of the greater palatine nerve and foramen compared to the opposite side. This makes a big difference, because if they just resected this and they missed out on this tumor can grow all the way up, involve the sphenopalatine ganglion, and potentially go back along Vidian's nerve or all the way along V2. So for us as the radiologist, anytime that you see an adenoid cystic carcinoma or squamous cell carcinoma, please remember the applied anatomy. This is what we learned in medical school. And what gets me so excited about head and neck radiology, and why, after 30 years, I still have the same passion that I do, is that over this 30 years, I've seen how we've directly affected patients and how they're treated. So this is an example of a patient that has a tumor extending into the pterygopalatine fossa. So draw a line down the middle, compare the right side to the left side. See the little fat right here? See how that fat's gone? That's tumor extending back here. Now, once the tumor goes in the pterygopalatine ganglion, it can jump along the sphenopalatine foramen, grow along V2, and grow back through foramen rotundum. And if I draw a line down the middle here, compare the right side to the left side, I think I can convince you. Notice the right side. You see this little target sign right here? This is the nerve, and this is the vascular plexus. Isn't that beautiful? That's a nice little nerve right here involving V2. Now, on the ipsilateral side, we see all of this enhancement. This is perineural spread along V2. Once it's along V2, it can grow all the way back into the cavernous sinus. And once it grows back in the cavernous sinus, it can involve the trigeminal ganglion in Meckel's cave. Notice the normal appearance here of Meckel's cave on the right. See the tumor here? And this is tumor growing all the way back into the trigeminal ganglion. So this is back in the skull base. So not only can we make this diagnosis, but 30 years ago when I started doing this, we first started looking at MR. And we're like, wow, we think we can actually see spread back into the cavernous sinus. Well, the next thing is that think how these patients are treated. The surgeons, in order to get this disease, would basically have to do a hemiheadectomy. They have to resect the sphenoid sinus. They have to resect the carotid artery. They have to resect cranial nerves 3, 4, V1, and 6. So basically, that's a hugely morbid procedure. But at that time, the surgeons didn't believe that we as radiologists could actually see this type of spread. So they said, oh, you radiologists, you can't see this. But one of the greatest things that I've seen over my 20 years is not only have we gotten better at making this diagnosis, but now our surgeons and our medical oncologists and our staging systems have now integrated into this in our staging systems. So at the institutions where I have been at now, if I say that patients now have this tumor extending back into the central skull base, they listen to us. They do not treat these patients with surgery and they avoid the morbidity. So now, not only can we make the diagnosis, but we've actually changed how these patients are treated. We are now moving this from a surgical approach to a non-surgical approach. And for me, that's been a really rewarding journey over the last few years that I've been doing this. So in summary, what I've done over the last 60 minutes or so is that we took a deep dive into the oral cavity. We talked about the buccal region, we talked about the floor of the mouth, the hard palate, the oral cavity, and the retromolar trigone. I hope you found this helpful. If you're interested, I do have a free YouTube channel. Akshay told me that we're going to try to upload this talk to that channel as well too. So if you are interested in head and neck, it's a free channel. We have about, I think, 17 talks on there if you're interested. And with that, Akshay, thank you for the honor of allowing me to give this talk and hopefully start this series. And I hope people found it beneficial and happy to take any questions that you would like. So thank you very much for your attention.
Wow, Suresh, that was just phenomenal. I was talking to Suresh earlier, and I have listened to a talk taken by him on oral cavity when I was a resident in 2011. And old wine only grows better, right? So that's what we are seeing today. So thank you so much for this. We
Thank you, Akshay. You're sweet.
so we have quite a few Q&As actually. So one thing is they're asking for the link to the YouTube channel. So maybe if you can put it in the chat box, and we'll
Yeah,
also
sure.
put it on all the groups.
Yeah, sure. It's my pleasure. And I have as much, my wife's out of town, so I have all the time in the world for questions. So happy to answer any questions. Just put in the chat box. Yeah.
Music to everyone's ears. But before that, I'm going to read this comment by Bethlehem. It says, "You just opened my eyes. Thanks a whole lot. Still, I look forward to learning more from your YouTube channel." So I mean, I don't think I've read that comment till now amongst the 800 webinars that you have just opened my eyes. So here are a few questions. Do we do puff cheek technique for MRI as well?
That's a good question. I haven't tried it. The thing about I think if you can do a quick sequence, I have seen occasional papers do it. So, yeah, fantastic. I think it's a great idea. It'll take a little bit of education. It'll take a little bit of education with the technologist, but I think it's certainly worth trying. I tend not to do it routinely, but I think it's a great idea.
So if you would want to do it, then which one or two sequences would you do it on?
That's a great question. So I think I'd probably do it. So this is interesting, actually. I'll give you my opinion on this. And again, a lot of stuff. I've grown older. When I was younger, I thought my opinion was fact and dogma. But as I've gotten older, I realize I'm not as smart as I thought I used to be. So now I say it's really my opinion on this. But for me, um, one of the most powerful things that we can use when we look at head neck imaging is that we can use the natural contrast that we have in our body. So that's why, I really, I've, if I show this case right here, can you see my screen, Akshay?
Yes, we can.
Yeah, so the thing that I like to do is the natural beauty of the tiger stripes and the natural contrast. So for me, if I'm looking at a tumor, in fact, just literally on today's Sunday. On Friday, one of my radiation oncologists called me, and we actually did a contouring of a recurrent esthesia neuroblastoma. And one thing that we always emphasize is that if you do have tumors like this, and I think I can switch to this one, is that the natural contrast and the non-contrast T1 weighted image is actually a very powerful way to look at the spread of tumors. So for me, if it's involving the lip right here, I can see the nice stripes right here. So I would actually do it on the non-contrast T1 weighted images because I would want to leverage the tiger stripes here between the muscle and the fat. So that's what I would probably prefer doing. But I'm open to other ideas.
I think that's a great suggestion to start with. Ivan is asking, or Ivan, I'm not sure how to pronounce the name, is asking how to differentiate early stage tumor from infection. Can you do it if without the history?
It's a great question. So I think you can. And so let me give an example, okay? It's a really, really good question. It's something that I struggle with. I have struggled with and I still struggle with. So let me show this case. Can you
Yes.
see my slide right here? Okay. So this is an example of an early stage, and I showed this earlier. This was lymphoma. So you see the lymphoma right here, right? And you can see, and look at the margins right here. So in an early stage tumor, you should have a pretty crisp transition between the tumor and the surrounding fat because it's early stage. So if I see something like this, then I'm thinking it's more tumor, especially if the patient is afebrile, obviously. Now, on the other hand, I think I showed this case. Now, this lesion, right, just ignore this area right here. If I see, let's just say this was all solid, and then I looked around and I saw all of this inflammation, from my standpoint, there's a disproportionate amount of inflammation and reticulation of the fat compared to the abnormality located adjacent to the buccal area. So in my own mind's eye, I think it's a great question because this is how I think, and you force me to speak how I think, which is hard for me to do sometimes. But if I see a disproportionate amount of inflammation with respect to the actual soft tissue mass, then I'm thinking more of an infection. But on the other hand, if I see a soft tissue mass without a lot of infiltration, then I'm more inclined to think that I'm dealing with an early stage tumor, as we see here.
Great. So, few anonymous questions. One attendee is asking, is the floor of the mouth the mylohyoid muscle or is it the sublingual gland?
Great. It's the mylohyoid muscle. So let me go back to that one. So Akshay, do you remember the teacup analogy, huh?
Absolutely.
So so here's the mylohyoid muscle here. See the mylohyoid muscle here? So the base of the floor of the mouth is the mylohyoid muscle, and the sublingual gland is just above it. So when I look at, basically it looks like a hammock. So this hammock right here, maybe I'll put a hammock in here one day, but this hammock right here forms the transition between the floor of the mouth and the submandibular space, and the sublingual gland is within the sublingual space.
Got it. A couple of questions on anatomy. Uh, can you show the alveolar margin and the alveolar ridge? Another question, the tonsillolingual sulcus.
Yep, sure. Tonsillingual. Okay, so let's see. Which one do you want to start off with first, Akshay?
Maybe tonsillolingual?
Okay. So the term the term that I like to use for this, and I've heard different terminologies used. The terminology that I like to use, let me go back to this one, is better. The term that I use with our surgeons is the glossotonsillar sulcus. So the tonsil, and this is really in the next talk. If you want me to do the talk on oropharynx next, Akshay, if you want to, did we do enough good job to come back? Are we good?
Yeah.
So, so the oropharynx really is the tonsil is part of the oropharynx, and then the tongue base is here. So the glossotonsillar sulcus or the glossolingual sulcus is really back here. So it's really part of the oropharynx, not the part of the oral cavity. But the bottom line is where this palatal-glossus muscle comes down, and the lower pole of the tonsil is. This area right here is the you can call it glossolingual. I call it the glossotonsillar sulcus. And then what was the other one, Akshay?
Alveolar margin and alveolar ridge. I thought you were offering to do the next talk next week.
Whatever you guys want. I love you guys. So the alveolar ridge and the alveolar margin are, it's a great question. It's essentially the same thing. So let me go to this image. This will probably show it best. So the alveolus technically is where the tooth socket inserts into. So this is the alveolus right here. And where the tooth inserts into is called the alveolar ridge. So I tend to use the alveolar ridge and the alveolar margin interchangeably. Now, this area right here along the medial portion of the mandible, is what we refer to as the lingual cortex because it's adjacent to the tongue. But this area right here, and let me see if I can mag that up a little bit. I think you can see my arrow, right, Akshay? So this is a nice example of the buccal cortex of the alveolar of the mandible, and this is the lip, and this is what we refer to as the gingivo buccal, because the buccal cortex is here, gingiva buccal sulcus. So alveolus, alveolar ridge, lingual cortex, buccal cortex, gingiva buccal sulcus, and then here's our lip, and this is probably part of that buccinator muscle here. So hopefully that answered that question.
Perfect. Another anonymous question, is DOI always less than tumor thickness by dimension?
Um, that's a great question. I don't know if I have enough data to say that, but in generally, yes, because in general, and now this is a generalization. In general, the majority of squamous cell carcinomas that you're going to be seeing are going to have a fair amount of bulk to it, as is seen here. So if you have your standard exophytic cancer involving the tongue, then the tumor width is going to be greater than the depth of invasion. Now, having said that, and I don't know if I removed this slide or not, because I know it's in one of my other talks. No, I think I removed it. There is a type of tumor that this is exophytic, okay? So you can see it's sort of bulging out. There's another type of tumor that we end up seeing where there's not an exophytic component, but instead of the tumor growing out, it grows in. And that's what we refer to as an ulcero-infiltrative tumor. Now, those ulcero-infiltrative tumors don't have a lot of thickness to it, but they burrow deeply to it. And in those specific ones, they're probably going to have a greater width than the depth of, they're probably going to have a greater depth of invasion as opposed to the tumor width because they're burrowing in as opposed to growing out. And when the tumors grow out, we can see it. But if they start to burrow in, then that depth of invasion is probably going to be greater than the amount of thickness that we can see on imaging. I don't think I've ever had 300 people on a Q&A session. This is awesome. So much interested in head and neck. That's
Yeah.
awesome. I love it.
It's just, I think that's the biggest testament of a talk being great, that the number of people who stay for the Q&A.
Oh, you're sweet. Thank you.
So anonymous. So there are a couple of questions on root and tongue, root of tongue. I think there's some confusion. One anonymous attendee is asking, is the root of tongue different from ventral tongue? And another one is
Yes.
asking, what is the difference between root of tongue and floor of oral cavity?
Yeah, that is such a great question. In fact, when I was going over that contouring session the other day, I asked that same question. So I can give you I can give you a historical view on this. So number one, when we look at the tongue has these components to it. So we have the oral tongue, we have the circumvallate papilla, and we have the tongue base. So when we look at this is how we subdivide the tongue. Now, back in the old days, and again, back in the old days, meaning when I was your age, Akshay, we used to talk about the root of the tongue. So what exactly is the root of the tongue? Clinically, the root of the tongue would be involved when a patient could not stick out their tongue. So you would have these super, super aggressive tumors that would end up burrowing inferiorly, and the musculature would be involved such as you could not stick your tongue out. So when we saw that and the patient could not stick their tongue out, we would know that the muscles that actually allow for movement of the tongue could not work. So that's clinically what was root of the tongue. Now, over the last 30 years, as imaging has now become front and center, it's been a little controversial as to what actually is root of tongue. So this is the way that I look at it. I look at it this way. So I'll try to be clear on this, is that when I see something that looks like this is the oral tongue. This is the circumvallate papilla, and this is the tongue base. Now you have to ask yourself, is that how do I know what this looks like on imaging? So when I look at the, let me go back to this image right here. I think unequivocally we can say that this is oral tongue. You can see my slide, right, Akshay, because it's kind of bland. It kind
Yes,
of looks rounded and so on and so forth. So that's oral tongue. Now, the next area that ends up happening is that when you start going more inferiorly to this level, so now what do you see? You see these two stripes, right? You see these two tiger stripes right here. This is the genioglossus geniochyoid complex. When I see these two stripes, which corresponds to this anatomy, then this is the floor of the mouth. Then the next question comes up is, where does the floor of mouth end and the tongue base begin? So can I convince you here is that as you're following these muscles back, these are oriented anterior to posterior. Do you see this right here? Yes? Now, see these muscles back here. See, these are transverse muscles right here. So when I see the transition between anterior, posterior to transverse, these is the tongue base, and this is the floor of the mouth. So when I lose my transition here, anterior to posterior to right to left, then that tells me that I'm at the level of the tongue base. So then the next question comes up is, what exactly is the root of the tongue? And let me see. Yeah, okay. This is probably the best example I have because it's pretty subtle. So Akshay, do you see this? I can convince you that this is floor mouth, right?
Mm-hmm.
Right. And I can convince you that this is tongue base here, right? Now, do you see this vessel right here? See that right here?
Mm-hmm.
This vessel is the lingual artery. Now, this gets down into some deep anatomy, but I figure if you're spending time on this talk already and you're listening to all this anatomy, you're going to dig the anatomy, right? So for me, when I talk about the root of the tongue, this artery right here, which runs deeply in the floor of the mouth, is the lingual artery. And adjacent to the lingual artery is the hypoglossal nerve. So for me, if I'm looking at a CT or an MRI scan and I see tumor that's extending down to the level where I can see the horizontal portion of the lingual artery, I know that the hypoglossal nerve is next to it. So for me, that's how I define the root of the tongue. That's my definition. Now, you'll have other speakers maybe give a different approach to it. But when I'm dealing with my surgeons and we're trying to figure out where someone should have either transoral robotic surgery or maybe they should be treated with chemotherapy and radiation therapy, I make a specific point to point out this horizontal segment of the lingual artery because they know then is that in order for them to resect the tumor, what they don't want to do is take out the hypoglossal nerve. So that to me is what I define as a root of the tongue. So I'm sorry for going on so long, but it's a really important question, and this is probably the right forum to answer that.
That was really helpful. I mean, I think many of us were unclear on this concept, so that's really thank you for that. Um, Vishnu is asking, do you give the T and M staging in the report? I mean, the T and the N, or do you just describe the extent of the tumor without putting the T stage in the impression?
Right. So that's a great question. So this is what I end up doing, Vishnu. So it's a great question. What I end up doing is that if I know a tumor is involving the oral cavity, I will go ahead and measure the tumor. So I always measure the size of the tumor because when you do look at the AJCC staging, as you can see here, the tumor size is still really predicated on what we measure. So I will, as I've done here, I think I did it on this, or maybe I didn't, I can kind of do it there. In a tumor like this, what I would end up doing is I would measure the largest dimension. And once I do that, I've sort of implicitly given the T stage. So what I will end up saying is I'll say radiographically, this would be staged as a blank and blank just based on the size. The challenge now with the AJC staging is that it does get into depth of invasion, and that's a microscopic diagnosis. So I've kind of backed away from it a little bit. But on the other hand, if I see specific markers, so for instance, if I see a tumor that's greater than 4 centimeters, and I know that greater than 4 centimeters is a T3, I'll go and say it's a T3. If I see bone erosion, I'll say there's bone erosion, and this would be consistent with a T4 lesion. So I'll put it that way. So I've had to, before we integrated the depth of invasion, I would always essentially include the T stage in it just because I'm familiar with it. But I've had to back away a little bit because now the depth of invasion is now integrated into that.
That's very useful. This is a good question by Mahmood. Um, between CT and MR for head neck tumors in general, when would you recommend CT and when would you recommend MR for local staging?
Yeah. Yeah, that's a great question. So again, like over time, I've evolved in this. So actually, if you asked me 10 years ago what I would do, my pat answer was the following. I said anything above the hard palate, I would do MR, and then anything hard palate or below, I would end up doing CT. Now, this is where I've kind of evolved over time, is that again, if it's involving the soft palate, nasopharynx, skull base, I would do MR as a first line treatment. If it's involving the skull base, I always do CT and MR for the reasons everyone knows. But on the other hand, if I'm in a situation where I'm working with techs that I know are very vigilant, that they're going to make sure that the patients don't move, and someone comes in with a tongue base or an oral tongue lesion, then I'll do MR on those patients. That really now is my frontline treatment. Tonsil cancers, oral pharynx, I like to do MR more than I do CT. So now for oral pharynx, I tend to do more MR than I do CT. But on the other hand, if I have a lesion that's involving the alveolar ridge or the gingival buccal sulcus that's sort of along the gingiva, then I'll probably do more CT because we want to look for that erosion. For larynx, I still do a lot of CT. I know my colleagues in Europe do a lot of MR. For us in the United States, a lot of the patients that have laryngeal tumors are smokers and drinkers. They have a hard time holding still over time. So I like to do CT on them in large part because it's so quick to do, it's so easy to do, and I feel a little bit more comfortable. I feel I can get a more reproducible image with CT than I can with MR. So I can't give a pat answer like I used to. It's a little bit more nuanced and complicated than I used to do. But anyway, hopefully that was helpful.
Wonderful. Omar is asking, what is the protocol for neck MR that you would adopt?
So that's a great question. You know, the answer, I'm going to say, I'm going to give you my approach on this because I do head neck. Like 80% of my practice is head neck. Then it's really hard to, for me, it really depends on where the tumor is. So I like to perform subspecialty head and neck imaging. So for instance, if I'm just have a general a patient quote unquote neck mass comes in, I like to keep it really simple. I know there's a lot of new MR techniques, but my philosophy is that, I use the imaging to better find the anatomy as opposed to being too focused on the technology. So I sort of use this little silly joke where sometimes when I get studies from the outside, there's an inverse relationship on the confidence of the radiologist based on how many sequences are performed. So sometimes if less sequences are performed and I read the report, I know the radiologist is very confident. But if I see like 15 sequences for just a regular neck mass, I'm like, okay, I kind of wonder sometimes. So for like a general neck MR, I just like sagittal T1s, axial T1s, pre and post, and axial T2s. And that's sort of really my standard my standard protocol, because that's going to really define the anatomy. And the other thing too is that the more you have the patient in the magnet, the more likely they're going to move. Because I don't know the last time you guys were in the MR magnet, it's loud, can be claustrophobic, so on. And invariably, the patients end up moving after you give contrast, because the last sequences that you do are the post-contrast sequence, and sometimes they're the most important. So that's why I like to keep my MRs short and sweet for general neck MRs. Now, on the other hand, we have dedicated protocols for patients that have, obviously everyone does IACs, but we have dedicated protocols for skull base. We have dedicated protocols for oral cavity, oral pharynx. We have dedicated protocols for carotid lesions. So we do have different layers of dedicated protocols just based on where the specific pathology is. So we do have our general neck stuff. We do have orbit MRs. We have IACs, which everyone has. But once you get down to individual subsites like oral cavity, oral pharynx, parotid, skull base, we have individual protocols for that.
Great. So, a couple of questions on post-radiation appearance. Heman is asking, wouldn't post-radiation destroy the tiger stripe? And another question is to check for recurrence, or for, what would you recommend, a CT, MR, or a PET?
Right. So, yeah, Hemant is exactly right. After radiation and chemotherapy, your tiger stripes can be gone. And I actually have a separate talk on that that we can give at some point. For those, Hemant's exactly right. The tiger stripes are gone. But what can be helpful is then you start looking for symmetry. So in general, if you're talking about patients that have uh, not necessarily tonsillar carcinomas, but laryngeal carcinomas, in general, the fields tend to be symmetric. So the post-treatment changes that we see tend to be symmetric. So you're 100% right. The tiger stripes at times can be gone. But on the other hand, if you have a tonsillar carcinoma that's left-sided, or a tongue-based cancer that's left-sided, now a radiation oncologist will give high-dose fields to one side and spare the opposite side. So you still kind of can use those tiger stripes and the symmetry to help you make a diagnosis. So it's probably better to show, maybe have that as a future talk or something like that if you're interested, and then I can specifically talk about that when we go over that. As far as follow-up is concerned, there's been a lot of stuff out there. There's tons of literature out there about appropriate follow-up. For me, this is the only thing I'm really dogmatic on, is that your imaging needs to be done no earlier than 3 months after completion of chemo and radiation therapy. Actually, I can't tell you how many times I've seen imaging done before 3 months, and it's really, really, what you end up imaging is the acute effects of radiation therapy or chemotherapy. So the only thing I'm really dogmatic on is that whatever imaging you do should be done at least 3 months after completion of therapy. Whether you do CT or MR, for me, depends on the site. If I have something that's oral pharynx, I tend to do more MR, and I like to do a dynamic sequences. It's not necessarily a true perfusion. I call it a poor man's perfusion. It's a dynamic gradient echo sequence, which I love. It was published like 30 years ago, and I've been using it for the last 30 years, and I'm very confident with that sequence. If the patient has a late stage, a more advanced tumor, then I like to follow those with PET CT. So in general, earlier stage tumors, if there's no evidence of recurrence, I think you can follow them with cross-sectional imaging. But on the other hand, advanced stage tumors, or if there's a higher likelihood of recurrence, then I tend to do more PET CT in those.
That's very useful. A question from an anonymous attendee. Glossopharyngeal is the same as the glossotonsillar sulcus. I mean, is asking whether it's the same thing.
Yeah, I think so. That's the thing about head and neck. We take the same piece of anatomy and we give it different names. So glossopharyngeal is just between the tongue and the pharynx. The tonsil is part of the pharynx, so that's why I called it glossotonsillar sulcus. But then I've also called it, somebody else earlier, one in the Q&A called it something else. So it's basically, they're all the same. But whoever asked that question is 100% right. They understand the concept.
Got it. Dr. Rajkumar is asking, sometimes we have these exophytic masses or lesions which can be seen clinically very easily, but are difficult to pick on CT and MR. Is there any special Suresh Mukherjee technique which can be used to identify them and catch them?
It's funny you should say that because I had a case literally 3 months ago where someone, first of all, hello Raj, good to hear from you. I had a case where the history was exophytic. It was an interesting case. The patient had a head and neck cancer, underwent intubation, and the anesthesiologist saw this polypoid mass, and when they intubated the patient and knocked off the mass, and so the anesthesiologist then told the ENT surgeon, yeah, there was a mass in that one specific area. And I couldn't see it. And I think I dictated out the report and I was completely wrong on it. And it's only after I talked to the referring physician that they said, well, this is exactly where it was. And when I went back and looked at it, lo and behold, there was thickening right in that specific location. And it was important because it was known squamous cell carcinoma, and the patient would have to get combined radiation and chemotherapy because it was posterior pharyngeal wall. So we did have to isolate. So my answer to Raj's question is number one, no. If it's like a sessile lesion that's pedunculated, sometimes they can be incredibly hard to see if they're small. So in those lesions, if I see something and the referring physician says there's a sessile mass there or just a mass there, I'll just call them up and I'll say, hey, where are you looking? Because I just don't see anything. And I would say, 9 times out of 10, the referring physicians are happy to hear from you because they know that means they know that you're making a special effort. So, I don't, because as you know, in these early stage lesions, the symmetry may not help. They're not deeply infiltrative, so you may not lose your tiger stripes. So I think getting on the phone and talking to your referring physicians in that case is what's helped me out a lot. So I don't have any magic wand for that one.
The last question from Sunny is differentiating macroglossia from edema from macroglossia by amyloid deposition. I suppose the history will have there.
Right. How do you do that?
Yeah, I'm assuming that she's asking if you don't have the history, then how do you do it?
Yeah, that's a good question. Yeah, I think I can answer that one. So if you look, can you see my screen, Akshay?
Yes.
So that one I think I can answer. And that's the following, is that if you look at the CT scan right here, can I convince you that this area more anteriorly is low attenuation? And this area more posteriorly is more dense? Can you see that transition from here to here? So the fact that it's low attenuation here, this indicates that there's more edema involved in the oral tongue. But then look at the amyloid. See how this is kind of diffusely, it has the same attenuation. So this attenuation is the same as this attenuation. So this tells me it's a little bit more solid. So for something like this, and I'm thinking about something that's intrinsically more infiltrative, whereas if I see the low attenuation here, this tells me I'm dealing more with edema. So that can help me separate out edema versus amyloid or some type of other diffusely infiltrative process.
Wow. So that I think answers all the Q&A, and that was 49 Q&As that you took over, Suresh. So that was just amazing. You have set a very high standard with this talk because now you are expected to answer 49 Q&As every time uh, for your future sessions. But I can't thank you enough. I mean, the comments just go on and on. Always amazing, even after 2.5 decades. Everyone is requesting you to, share the YouTube link, and of course, we'll share it on our groups as well. Excellent presentation. So systematic, perfect, precise, and Peter Som and Mukherjee is the best book. Yeah, so I agree with that absolutely. Yeah, so I'll share the comments actually with you. because they're just really incredible to read. Thank you so much, Suresh, and it was a pleasure having you. And thank you to all the attendees. And we are really looking forward to the rest of the sessions.
Oh, no, thanks for putting on the session. And I guess I'll just end with this. As I've gotten older, I realize I'm not smart enough to create an iPhone or anything like that. So, what gives me pleasure is trying to, change the world one person at a time. And so on the other hand, if we can, at some point in the interaction, if we can have a positive influence or somehow help people on a daily basis, that's good enough for me. So that's why I appreciate the opportunity and, thank you for doing such a fantastic job. I remember when Bhavan started this years ago, and you've just again taken it to a new level. So I'm delighted to continue this, and thank you and all the attendees for taking the time to attend.
Thanks a lot. Suresh. If I can say that you already are a legend and you have created a legacy, and it's actually our privilege to be a part of that legacy in some fashion by, having you take these. So thank you so much.
Okay, you guys have a great day. Happy Sunday to you, and good luck to India. You have to let me know who wins the cricket match.
Absolutely.
Okay, take care.
Okay, bye.
All right, bye bye. Bye bye.